Thank you to the Southeastern Coastal Center for my invitation to be here today. Here it is. So I am in that more of that sports medicine, athletic training side of things. So I'm a little far removed from the agricultural thing, but I've learned a lot today, and I look forward to seeing where our research areas could come together. I am on the Medical and Science Advisory Board for the Corey Stringer Institute out of the University of Connecticut, whose mission is to prevent sudden death in sport, mostly heat stroke, but looking at other reasons why athletes die. So that's kind of where my research has been. But for today, I'm going to look at a brief epidemiology of heat-related illness and talk about just acute management of when somebody does have a heat illness, and then most importantly, if they survive the heat illness, what are we doing to get this person back to working in the heat safely? So like I said, this isn't really my area as far as epidemiology in the occupational setting, but I did pull a couple of studies that looked at the epidemiology of heat-related death in the US with occupational settings, where you saw that the majority of the cases, not surprisingly, and has already been mentioned today, happened during the summer months. Agriculture had a 35-time increased risk of heat-related death, followed by construction, so definitely there is a risk of death from heat illness. One of my main goals in life is to prevent people from dying from heat stroke, particularly since, at least in the athletic setting, we have figured out how to prevent somebody from dying once a heat stroke does occur. But I also wanted to highlight this other study that looked at these over 8,000 heat-related emergency department and hospitalizations in the occupational setting, specifically in the Southeast. They found that out-of-state workers were not acclimated, not surprisingly, to the heat and humidity of the Southeast. Many of these cases occurred during the first days of exposure, showing signs of lack of heat acclimatization in that particular group. Those with comorbidities were at greater risk for a more serious condition. And again, this study found that the May through September were the highest risk. So why is this important? Is particularly looking at this high number of heat-related illnesses, people that are not dying, but I'm guessing, I'm not sure what's in place as far as are they safe enough to go back to work, particularly when you're looking at people whose livelihoods and family and salary and all that comes from working. I don't know how much PTO they're going to have after a heat-related illness. So based on this epidemiological study, they had no heat illness prevention program, which leads me to believe that they also do not have a return to work program set in place to safely get them back to working in the extreme environment. So what happens when they leave the emergency department and return to work, and is a risk of heat illness, exertional heat illness, still present? So I want to look at just a brief overview of the exertional heat illnesses as defined through the National Athletic Trainers Association, which is my profession's position statement, and look at just brief recognition and management, what to do in the case of a heat illness, and then secondly, how do you make the decision to allow that worker to go back to work? So exercise-associated muscle cramps, so everybody is pretty familiar with this one, a very mild heat illness. Nobody dies from heat cramps. But they could definitely keep somebody from working, particularly if they have that strong muscular contraction and they're unable to relax that muscle. So initial treatment, there's a basic theory: is it electrolyte depletion or is it muscle fatigue? And the answer is we don't know yet, but it's probably a combination of both. So as far as return to work and clearance from this condition, exercise or work as tolerable, determine the cause of it. It could be a nutritional diet analysis that needs to be done if they're not getting the nutrients they need to prevent this. It could be a lack of being accustomed to the type of work they're doing. But most importantly, and this is a whole other conversation for another day, is if they have sickle cell trait, do they have muscle pain associated with exertional sickling? And then heat syncope is more just, the fainting or collapse, usually from standing in the same spot for a long time, usually happens from the venous pooling of blood to the extremities and standing in the same place for a long time. Initial treatment would be to move to a cooler area, monitor their vital signs, elevate their legs, cool the skin, rehydrate. And I'm not sure, again, it's by any means necessary as far as cooling for heat illnesses, because if you're out in the field, you probably have limited resources, but any kind of cooling. And pretty much with heat syncope, just like any other fainting episode, if you can keep them in the cool area and hydrate them, they usually feel a little bit better soon afterwards. As far as clearance, the most important thing here as a healthcare provider would be to find out why they fainted. Is it heat syncope, or is it a more serious condition related to cardiac or other condition or reason for fainting? So and most of the time, again, it's lack of heat acclimatization, and the most important thing would be determine why they did faint and make sure that that issue is addressed before they go back to work. Moving on to heat exhaustion, and I know that Dr. Saka mentioned a little bit about heat exhaustion. It is mostly cardiovascular insufficiency, you know, that stress of the heat, of that blood flow going to the skin and not enough going to working muscles and everything else that's happening. But the on-site treatment would be if they have extra clothing or equipment. We talked about, you know, the barriers for the pesticides and all that. More clothing like that could prevent that ability to dissipate heat through evaporation of their sweat. So removing excess clothing, moving them to a cooler area. And again, any kind of body cooling like ice towels or ice packs, dousing them with cold ice water, things like that should help them feel better pretty soon. Fluid replacement if possible, meaning if they're not vomiting and they're able to ingest fluids by mouth would be the best. Second to IV if that is available, but I realize that that is not always a logistical possibility. And then more importantly, follow-up treatment is if somebody does experience a heat illness, heat exhaustion, they don't feel well, they're feeling faint, they're out working in the heat, is find out what happened. Did they not drink enough fluids that day? Are they sodium depleted? Are they not heat acclimatized? Because when it comes down to making a decision of if somebody is able to return back to working in the heat, you need to find out if the original cause that led to that is still present, then the answer is no, they shouldn't be going back out there to work in the heat. So looking at ruling out heat stroke, making sure that it's not a more severe condition by looking at, you know, blood levels of CK or liver enzymes, ensure that the cause is eliminated. You could do easy urine color, USG, just to see if when they arrive the next day, have they replaced those lost fluids and are they in a euhydrated state to be out there working in a hot environment. And then moving on to the heat stroke, which I think is the most important one, mostly because it's the fatal one, right? So it's a medical emergency. So it is a medical emergency defined by hyperthermia greater than 40.5 C or 105 Fahrenheit, usually with organ damage, CNS dysfunction, as Dr. Saka mentioned. Usually result of metabolic heat production, environmental heat load, but it's important to realize that heat stroke is multifactorial. There are so many intrinsic and extrinsic factors that result in heat stroke that somebody doesn't get heat stroke just because it's hot outside or just because they're dehydrated. There are so many different factors that go into this. This is a very brief pathophysiology of heat stroke. Again, I know that's been discussed already today, but at the top, you can see compensable heat stress with extrinsic and intrinsic factors, and our bodies do a pretty good job of adapting to the environment and making sure that we're able to continue to function. However, for various reasons, you could have this metabolic cascade with dehydration, the leaky gut that was mentioned, decreased liver function, acute renal failure, and a whole series of things that cause somebody to die from exertional heat stroke. So a good way to prevent that, not exactly that heat stroke is preventable, but somebody dying from heat stroke is to get their body temperature down as fast as possible. So when you look at the literature regarding why, particularly in the athletic population, why athletes have died from exertional heat stroke, it comes down to misdiagnosis if they don't have an accurate body temperature, a delay in care or treatment, inefficient cooling modality, immediate transport, and most importantly, returning to activity too soon. So if that person has not recovered from their heat stroke and now they go back to the same exact environment that caused it, they're at a greater risk of having subsequent issues with the heat. So looking at the clinical presentations, core temperature greater than 105, as I mentioned, CNS dysfunction and difficulty breathing, hyperventilation, et cetera. The other issues will be seen more in the hospital clinic setting, but on site, those first three are the ones that are kind of like the signs and symptoms that you'll see when somebody collapses with exertional heat stroke. This is from a 2018 consensus on pre-hospital care of a heat stroke patient. So it's really the latest consensus statement on how to prevent somebody from dying from heat stroke before they even get to the hospital, because a lot of it has to do with how that patient is initially cared for at the time of collapse. And the truth of it is rapid recognition, assessing them, their temperature, and then aggressive cooling on site. The best way to cool somebody on site is some kind of cold tub, water immersion with ice and water. If that's not available, using a tarp to create such of like a little mini pool or kiddie pool. If that's not available, any kind of means of cooling them through ice and water to get their temperature down is the goal. And what we have seen in the athletic setting is that when somebody is cooled on site, it's properly recognized, and they're cooled aggressively, they survive. As far as I know of 0 cases of somebody having heat stroke, is adequately and timely recognized, treated, and that they have died. So it's pretty much 100% survival when we have seen this in the athletic setting. So after somebody has a heat stroke, the next question becomes, when are they ready to return to work? And this is something that needs a lot more research in this area. There's very minimal research, I would say, or definitely not enough to have conclusive evidence on this. But the questions that I would ask are, has the individual recovered from the heat stroke? What caused it to begin with? And then what are their needs and requirements in the activity of work? So if they had a heat stroke randomly not associated with work, and now they're going to go back to working in the air conditioning, then they're okay. But if their work requires them to do hard labor in the hot and humid environment again, then that definitely changes the question of when they're able to go back to work. And then as a side note is, how could this be prevented? If you know the cause and it's a common theme, something organizational factors that could be modified, then you need to go back as an organization and say, is there something we could have done better? Whether it's more breaks, whether it's rest in the shaded area, and more access to fluids, or anything like that. So I had an opportunity to work with a high school football player that had an exertional heat stroke, and I was working with the physician on when can this athlete go back to play football. And so these are the kind of the themes that we came up with working with this individual patient, which the questions that I just posed to you as far as, has he recovered physiologically, did he have normal lab values, did he have any kind of sequelae revolving around the heat stroke, and then did he have physician clearance? As far as what caused it, there are so many factors I'm going to talk about in a second, but level of heat acclimatization, physical fitness, and all that. And the point is, if the reasons that, like I mentioned, that caused it are still present, then those need to be addressed before that person can safely go back. And then lastly, what are the requirements? For this particular athlete, he was a defensive end football player, so he had to wear the equipment. He had to go back to working high intensity, really fast, short bouts of exercise, and we basically addressed those before we allowed him to go full return back to football. So hitting on each of those questions individually, has the individual recovered? You want to look at liver enzymes, renal function, creatine kinase levels have been mentioned because a lot of victims or patients of heat stroke also have exertional rhabdomyolysis associated with that, so they have a lot of muscle damage that occurs. Heat intolerance or temporary heat intolerance, there are some people that do have lingering issues with heat tolerance to the point where some people are temporarily heat intolerant and some people are longer than that. Some people are not able to actually go back to work after that occurs. So again, heat intolerance would be defined as lower thermoregulatory efficiency and unable to adapt to exercise in the hot environments. So when we look at recovery, in our research, it's been directly tied to how well the heat stroke was managed. And that's why looking at the management of the heat stroke on site first could really help guide the recovery process. So was there a prompt recognition, and was the person individually individual aggressively cooled? And the answer is, if there's a late intervention, so if the person collapses, they call 911 and that person is sent to the hospital. In the meantime, there's no aggressive cooling happening, the prognosis is poor. So you have a greater chance of that person either dying or having permanent damage, whether it's liver issues or renal failure, things of that nature. So the goal here is to get their temperature down, ideally, definitely under 105, ideally 102.5 before they're even transported to the emergency department. And then looking at the different issues, this figure is actually from a case study in the Marine Corps Marathon where we had a runner that collapsed at the finish line and was sent to the medical tent. We cooled him aggressively, and then another person collapsed on the course. They weren't able to get him to the medical tent, so they sent him directly to the hospital. And what happened was, because there was a delay in the cooling with him, he was intolerant and was discharged from the military, so he was not able to go back to his military work. So again, the importance of that, I know this has been shared already, but looking at these values to know what the normal values are, especially the liver enzymes and the CK levels, and whether or not that has stabilized before they go back to working in the heat. As far as causes of return to activity, or causes of heat stroke, again, it's multifactorial. So if you look at this list, And the next slide I'm going to show you, you want to use these factors that cause the heat stroke as a guideline to the return to activity process. So organizational factors we talked about, are they heat acclimatized? Is this their first day was that their first day on the job, first 2-3 days of the job, and they weren't used to that environment? Is it work to rest ratio where they're not getting the breaks, and maybe the breaks are not in a shaded, cooler area that they're going to need in order to get their temperatures back down? Any kind of modifications based on environmental conditions, and then recognition and treatment. And then from physiological standpoint, I know we talked about individual variability of what causes somebody to have a heat stroke on one day and not the other. And there are so many factors like lack of sleep, any illness, infection that they have going on that particular day, medications that they're taking that could increase their temperature or increase their susceptibility to have elevated body temperature that day, body composition, poor physical fitness, and there's a number of factors that could lead to somebody having a heat stroke on any given day. So looking at current guidelines for return to activity, like I mentioned, there's only some information out there. In the military setting, particularly Israeli military, they have a long history of using heat tolerant testing. I know a couple of us were talking about this last night. In the athletic setting, you look more at the American College of Sports Medicine, NATA, Corey Stringer Institute, and just what we have are just case reports of people with heat strokes and what they did particularly for those individuals, but there aren't really great specific guidelines on what to do. And back in 2010, this was published by ACSM and Department of Defense Roundtable, and they basically found that there's no comprehensive validated guidelines or recommendations for return to activity or returning to military duty. So some of the recommendations were make sure that they're asymptomatic, normal labs, and then cautious reintroduction. So not just going back to work and picking up where you left off, but a gradual reintroduction to make sure that, if they're able to work, more breaks in between, maybe half a day, see how they feel, then the next day increase the work exposure a little bit more. And then ACSM recommendations are no activity for 7 days following release from medical care, follow up 1 week post-incident. And I'd be curious, especially in the roundtable discussion later, to find out how this works in the agricultural world. Can somebody just take a week off of work and wait till they introduce? Probably likely not. So that there's a definite risk there if somebody's having a heat stroke and then automatically forced for whatever reason to go back activity on the next day. So once they're cleared, begin activity, cool environment. I realize we don't have control over that many times as well. And then a gradual increase in the heat exposure and the amount of work that they're being asked to do. And ATA recommendations are pretty similar. The key is physician clearance, normal blood work, and gradual reintroduction, low intensity to high intensity, using signs and symptoms. If somebody's going back to work and they're showing signs of heat illness, they should stop, and maybe they're not ready to do that. So before it becomes a more serious issue, it's kind of look out to see how they're responding to that work and the heat before they go full go. And as best you can, using whether it's the gastrointestinal pills or heart rate monitors to monitor their physiological responses, because that will definitely show you how they're doing in response to the heat. Again, the progression should be slowed or delayed, especially if they're showing significant signs and symptoms of heat stress. They should definitely stop for that day and reassess the situation. These are examples of some recommendations for heat acclimatization for work that Dr. Ashley and I have worked on. Basically looking at, if you can't control the environment, then maybe we could control other factors associated with that. So if somebody is not heat acclimatized, looking at the percentage of time spent working in a hot environment. I'm not going to go too far into it because I know that she is, so I'm going to skip through this. And then this one was more a re-acclimatization. So if somebody is injured, they have a heat illness, or they're injured, orthopedic injury or anything like that, and they're out of work for a specific amount of time, then depending on how long their absence is, and especially if it's due to illness, then looking at their level of risk and then giving certain percentages about the amount of work that they should be doing when they return. But I'm going to guess that in some of the work settings, they could have heat stroke, they leave the hospital if they make it alive, and then they go to work and they don't have a say in what percentage of work they do on the next day. So that is definitely a risk of re-injury, increased heat illness, and I'd be really curious to see if there's any epidemiological research on the fatalities of heat stroke in the occupational setting and whether or not they had a previous incident and maybe they weren't fully recovered at the time that the death occurred. That would be really interesting to see. So I just want to briefly talk about heat tolerance testing. Like I mentioned, it's been used in the Israeli Defense Forces. Basically, it's a treadmill test for 2 hours looking at 2 key measures, core temperature and heart rate, as well as sweat rate. And then there's cutoffs. They're just walking in the heat. So they look at to see if there's a spike in the temperature or a spike in the heart rate as a result of that work stress in the heat, in the hot environment. The idea is that you're looking for a plateau during this heat tolerance test. It is controversial. From my discussions a few years ago with some of the people in the military, and I'm sure Dr. Saka could speak to this, is they don't really use it here in the U.S. Some people have used it sparingly, maybe for specific cases, but they don't rely solely on that for return to duty decisions. They're not sure if it could really predict future heat stroke, whether or not it has the ability to measure potential deficits in thermal regulation. So there are a lot of different factors that are associated with thermal regulation, so there might be other factors that the heat tolerance test is not really picking up on. So this is just an example, though, of somebody that they took the test 2 months after the heat stroke and then 5 months, and you could see that the big difference, there was a definite spike the first time they took the test, both in core temperature and heart rate, and then on 5 months time point, it did more plateau. So it might not be the be-all, end-all answer to whether somebody is ready to go, but it can be a useful tool to at least just based on this example, you could see a stark difference from month 2 to month 5 post-injury that they were able to tolerate the exercise better. And then again, as I mentioned, some people are heat intolerant temporarily after a heat stroke, and some people are just heat intolerant. So this is another example of showing different candidate A and candidate B on the right after a heat stroke for several months, and then they kept retesting them. This person was deemed heat intolerant initially, but after several months of recovery, they actually did become heat tolerant. So while this person on the right was not heat tolerant, according to this heat tolerance test. And I really like this algorithm because it's a return to duty following exertional heat stroke, and I apologize that it's fuzzy. I'm happy to share this if anybody is interested. But you have a warrior athlete, this is for the military, that has a heat stroke event. After 1 or 2 weeks of rest, they have a clinical assessment, normal exam, yes, begin light exercise, gradually increase the workload and heat exposure over 2 weeks. Has exercise progressed normally? Yes, and then you clear them. And then whereas if you get here, they exercise for 2 weeks. If exercise has not progressed normally, they've had symptoms, they've had setbacks, then they recommend trying a heat tolerance test to see. So they don't use a heat tolerance test automatically. It's more like if they're not able to progress with their work, then they move on to using that as an additional tool to determine if they're heat intolerant. So what you need if you're trying to get somebody back to work following a heat stroke, in my opinion, is to monitor their heart rate, monitor their body temperature at some point. Ideally, this is being supervised by a healthcare provider of some sort to make the clinical decisions as to whether or not that person is able to safely return back to work. Monitor their signs and symptoms of heat stress, and if they have any kind of setback, hold them back and reassess to see maybe decrease the amount of work, maybe it decrease the amount of equipment that they're wearing that day, or the increase their rest breaks, increase their hydration breaks, things of that nature. Assess their hydration to make sure that they're doing what they can on their part. Whether you check body weights, urine color, specific gravity, fluid consumed, monitor their sweat rate. Exercise and work protocol should be gradually increased, potentially working with a supervisor to make sure that they're not overdoing it when they first return. And most importantly, that it matches their work environment, that it matches their ability to physically complete the work that they're being asked to do. So I know I'm running out of time. In conclusion, death from exertional heat stroke, from what we have seen in the athletic setting, is preventable with proper recognition and cooling. Everybody should have a plan on how to treat it on site. So yes, you want to call 911. Yes, it's a medical emergency, but while you wait for them, there's definitely some cooling that could be done on site. The key is to determine what caused it. So if that person survives from heat stroke, then what caused it so that you could address those issues before they go back to their work environment. And then the key for a gradual return is gradual increase in intensity. Acclimatization is definitely the key to making sure that they could safely return to extreme environment. And it's important to note that somebody could go to the hospital with exertional heat stroke, they could survive, but that doesn't necessarily mean that they're going to be heat tolerant or able to continue to work in the environment that they were when it occurred. So I don't know if we have time for questions, but I will gladly take any.
Thank you.
Yeah, sure.
The slide that you had, I don't know what number the slide was, but the slide that you had that talked about like what healthcare providers should be looking for in terms of, the adaptability to return to work.
Mm-hmm.
I think that's really important for providers to know.
This one?
No, it's further,
Okay.
much further back.
Okay.
With farm workers and a lot of immigrant workers, providers don't even ask what kind of work they were doing. And so, and then you have all kinds of issues, and I'm sure everybody knows this, you have all kinds of issues of people, language barriers, people going to the doctor once and not being able to return because of work or because of their migrating. So it's kind of distressing to me to see that and see how important that is, and yet know that health providers aren't really attuned to any of that. And so that being said, I mean, this is really interesting, and I wonder if there's any effort. I know OSHA has recommendations. Their recommendations are rest, shade, and hydration. But it seems like they should have recommendations also. Not that it would necessarily work in the agricultural setting, but at least that there should be some national standard recommendations from OSHA that also include the return to activity or return to work. So I don't know if that is, if there's any work with OSHA to try and get some of those recommendations implemented through OSHA, because it seems like that's like really super important, because even though farm workers and other immigrant workers don't have much choice, at least if there's national recommendations, some employers maybe might be more inclined to be conscious of that.
Right.
Or at least some health providers might be more conscious of that too.
Right, and I'm not familiar with that, but if OSHA wants to call me, I would gladly work with them to come up with those.
There's also DOD recommendations, which are weekly.
Okay, thank you.
Thank you.
I really enjoyed the presentation. You mentioned that after the experience, some people may be intolerant to the heat for a short period of time or a longer period of time. Do we know what is affected? What are the parts of the mechanisms of response that are affected? Is it in the gut? Is it the cardiovascular system? What is connected with that intolerance?
I should have put a slide on that. In my experience, it seems like all of your systems could be affected. So you could have muscle damage with exertional rhabdomyolysis. You could have cardiovascular insufficiency and issues with cardiovascular. So there's a number. It could be your, renal failure. So it really, I'm not sure specifically which system. It could be different ones for different people depending on what was affected with their heat stroke. So I know, for example, the one football player that I worked with, he had renal failure when he was in the hospital for 11 days. And he had to go to a specialist for that. He also had to have an EKG and a full stress test with a cardiologist to make sure. So he was working with so many different physicians to get clearance to make sure all of the systems were working. So it could be a number of different things. It could be your thermoregulatory system, your body is not able to thermoregulate for whether it's a sweating response or something like that. But it could be a number of different things.
Thank you for the great presentation. I think the rapid cooling is something we need to pay attention to, because this morning when I had the slide on the deaths, the young woman who died in California, they put her in the back of the van and stopped at a drugstore and got bottles of alcohol and doused it on her, trying to cool her. The worker in Immokalee, they told him to rest and then put him on the bus to go back from the fields to Immokalee. So, I think OSHA should look at mandating cooling blankets and when the temperature reaches a certain time, because I think they would cool these people down if they had the equipment, but they don't have the same thing that athletes have on the sideline, right, with the Gatorade things full of ice. They don't have anything to cool down. Right, so
I would recommend even as simple as a tarp, like a tarp, and access, if they have access to water and ice. Because I know in the athletic setting, people are trying to make a product. Everybody's trying to make a cooling blanket or a cooling vest or a cooling this, and a lot of times what we found from the research from that is that they're not really effective in actually bringing their core body temperature down. But ice and water so far has been extremely effective. So just having access to some kind of tarp that they could put in the back of the truck instead of putting alcohol, just use ice and water. But I think it's a lot of miseducation on that. Mhm. Right.
Well, I was just going to comment. I mean, I had a nice conversation with Mike over lunch and that sort of thing, and frankly threw up my hands a little bit because, while there's lots of other industries and occupational sectors that have a vested interest in the workforce, well, sadly, this isn't one of them. But at the end of the day, if plunging a worker into water is something that it can at least be helpful. It may be more of a conversation this afternoon, but it would be nice to see the center, perhaps under the law school, leading some kind of an initiative regarding how can you fold in some basic things like having tarps and ice water and those kinds of things available, and maybe perhaps as part of the field sanitation, some sort of an amendment to the field sanitation rules that are out there. I think that kind of an outcome would be a really nice center-related activity.
Yep. Over here.
You don't have to expend a lot of money. DOD's used is, we've developed, not we, but DOD, started actually before Benning, and there's epidemiological support as effectiveness. They call it a burrito, but it's a sheet get a bucket of ice, you put a sheet in and you wrap it, you wrap the person in it. And, in the athletic trainings, they put an emphasis on a drop in core. I think, though, in DOD, we think that if you cool the skin, that's important because it causes that infusion of blood. And certainly there's no harm in dropping the core, but this at least allows that auto infusion and some additional cooling. So you could do it cheap.
Can you talk a little bit more about that sleep deprivation, its correlation with heat stress, and what constitutes sleep deprivation?
Yeah, I haven't done any sleep studies specifically on that, but what I have seen from the research, both in the military and in individual cases of heat stroke, they found that when somebody did not have enough sleep, I would think it's circadian rhythm and hormonal responses to lack of sleep that may have made people more predisposed. But again, it's not sleep deprivation alone. It's sleep deprivation, dehydration, it's hot outside, you're working at a higher intensity. So that's one piece of the puzzle. But are you going to respond to that?
Yeah, we've done the sleep dep studies, and sleep deprivation doesn't change how you thermoregulate. It's thought to believe it's a covariant. If you're sick or something, you don't sleep as well. So it pops up sleep deprivation, but it might be a sign of previous sickness or,
Thank you very
Okay,
much.
thank you.